the commissioners will recall that at our meeting in Washington, we got into a conversation on the several modalities that can generate incidental findings. Lisa Lee led that for us, our executive director. But for the remainder of the day, we are going to focus on the contexts within which those modalities generate incidental findings. And we've had a conversation on those research, clinical, and DTC. Several of our members, those in the audience, might be interested in knowing. We split the members up into small groups to address each of these contexts, and over the last couple of months, through their deliberations and the cracking whips of our staff, made terrific progress on thoughts and recommendations in each of these areas. So this next session, we're going to focus on clinical context, and Dan Solmesy is our leader for that. Dan?
Well, thanks. This becomes a good opportunity to get feedback from the other task forces for each other, because I'm sure you all have something to say about clinical context as much as we might for research or direct-to-consumer advertising. Just again to refresh everybody's memories, we come into this not just maybe we started on this question of incidental findings because of research and particularly genetics, but in reflecting on it, obviously, it's a big issue that really hasn't gotten a lot of attention in clinical medicine. Blood testing packages, the comprehensive metabolic panel. If you you can't just ask for one extractable nuclear antigen, you get a panel of them. Body fluid analyses, you get a host of viruses, whether you were looking for one or another. Radiology, you can find an X-ray that gets a pulmonary nodule, a renal cyst, or an unidentified bright object on an MRI scan. Screening for newborns, coming genetic clinical testing. We talked a little bit even in the last session about whole body scans, CT scan for screening purposes, CT scans for coronary calcium scores, which can obviously demonstrate other things as well. And we added to some of that also clinical databases. So what if there are stored data on individuals and some new finding comes out that could be potentially actionable, stored samples that could be potentially clinically actionable as well. So there's a whole host of clinical questions outside of the research context. And just before we get into the specifics of our recommendations, also to say that we, in some ways, agreed with Henry, and I think what seemed to be everybody else here, that in the clinical context at least, that just the role responsibility of being a physician seems to supply all the sort of ammunition you need to say there's a responsibility here, that we don't have to get into a particular analysis about duties to rescue or anything outside of that. The professional duties of beneficence to help patients, non-maleficence to protect them from iatrogenic harms in particular, respecting them as persons and their right to know, but also tempered by, even in this context, questions of justice in terms of putting this as policy. How far can we go in terms of this? What can the nation afford? But beyond that, we thought there were two virtues that were really important to think about that will come up in some of this. One was to point out the irreducibility of prudential judgment from clinicians in this regard. Part of the discussion we just heard is there are just so many possible cases that to try to write rules that would give us the absolute duty in every single case will be virtually impossible. I'm sort of reminded by the urge to do that reminds me of T.S. Eliot's line of those who would dream of societies that are so perfect no one needs to be good. That we really can't do that in this particular case. And then also these duties of fidelity beyond merely even a fiduciary sense, I think, in the clinician's sense of trustworthiness and the willingness to go a bit beyond the ordinary for the sake of the patient's good become critical virtues in terms of thinking about this. So that's just by way of general background from our discussions, then to the actual findings. The first, we suggested that little is known about the cost effectiveness of tests and procedures that give rise to incidental findings in order to adequately evaluate the costs and benefits of ordering a battery of tests versus selective tests. And you may know that, for instance, it is now, we're urged not to just order a calcium because it's cheaper to get the whole panel of 20 tests rather than to do the selective test. But we don't really know whether that's actually cost effective. It seems so in the short run, but the generation of of incidental findings and ancillary testing may make that, in fact, more expensive, and no one knows. So our first proposal is that cost effectiveness studies should be commissioned to research the costs and benefits of ordering batteries of tests versus selective diagnostic tests. And these studies should assess the long-term costs of conducting follow-up testing on incidental findings, which to our knowledge of, and at least brief reading of the literature, no one has really done. I think would be very significant in terms of clinical incidental findings. And again, I'll use incidental findings as this term of art, which is a broad covering term to cover all those sorts of things we're thinking about. Second, in terms of the role of professional judgment in managing incidental findings, our second clinical finding from our task force was that particularly in light of the current lack of empirical evidence regarding costs and benefits of discovering incidental findings, effectively managing them, and the irreducible nature of the individual practice, that this will all require a clinician's professional judgment, combining clinical and ethical decision-making in deciding what to do about particular findings. And so our second proposal is that medical educators should teach the judgment and analytic skills necessary in clinical coursework for students to engage in professional judgment with prudence and confidence. And again, there's just, this is sort of maybe motherhood and apple pie, but it is really dramatic as an observation for the three of us as medical educators, how little focus is given in medical education to this. Sometimes it's done in terms of cost effectiveness, but not even in the sense of trying to sort of say what ought we work up, what ought we not work up, and to make those kinds of judgments and to sort of reinvigorate teaching about that part of practice. Our third clinical finding is that while a clinician's fiduciary duty requires all of us to review all the clinical data that our tests generate, that we shouldn't we shouldn't bracket or ignore potential incidental findings. This goes back to the sort of filtering question that Christine was suggesting, that we have a duty, if we've ordered the test, that we shouldn't actually purposefully filter it for reasons that perhaps Henry Richardson suggested would be morally suspect. If we've ordered it, we really ought to look at it. However, this duty to look does not require clinicians to conduct additional tests or additional analyses of data with the sole purpose of discovering findings incidental to the purpose of the diagnostic testing. So we want to sort of balance it that way. So our proposal then, related to this finding, is that professional organizations and medical associations should really develop and implement evidence-based clinical practice guidelines and best practices for handling incidental findings that address decision-making strategies under these conditions of uncertainty, and encourage selective use of focused diagnostic tests and procedures, even to confirm suspected diagnoses. Our fourth clinical finding is that public beneficence does require us to engage in screening programs but that they be based on empirical cost-effectiveness data, taking into account the follow-up testing and clinical care resulting from incidental findings. Again, the point here is that there's a lot of enthusiasm, particularly in our nation, for screening. But there's very little in the way of testing that's often done before we implement screening to prove the long-term effectiveness and safety of those screening measures, including, again, the generation of incidental findings through these screening tests. And so our proposal is that professional organizations should produce evidence-based standards for proposed screening programs that take into account costs and benefits associated with incidental findings. And screening programs should be implemented only if they're evidence-based, including this kind of data as well. Again, people who do screening tests and study them often just look for the short-term gains, but don't take into account the full panoply of what can happen once one sets this set of screening tests into motion. And if incidental findings arise from screening programs, nonetheless, professional organizations should also provide guidance regarding the best practices for their management. So whatever screening test we will develop, ought to first look for, take account of the possibility of incidental findings and take that into account in whether it's ultimately recommended. And then, when it does, recognize that even when implemented and appropriately accounting for these findings, that they will still be generated and we ought to have ways of dealing with them. Our next set of findings are with respect to clinician-patient communication regarding incidental findings. The fifth finding then of our little working group was that because of the possible clinical importance and follow-up requirements of incidental findings, respect for persons and patient autonomy will require that clinicians inform patients about the possibility of incidental findings for certain tests and give patients the opportunity to express preferences regarding whether they want to know the results. Now, this is difficult, I think. It's burdensome enough to get informed consent from patients, and we recognize that. But again, too often, before that test is done, no one tends to discuss the possibility of incidental findings being generated by these tests as part of the informed consent discussion. And beyond that, what series of likely events might happen if there are incidental findings generated. So I think that this is potentially burdensome, but I think an important recommendation. Open questions that we have regarding this kind of conversation, if it takes place, is what happens if the patient expresses a wish not to learn about the incidental findings? Are there circumstances under which those wishes should be overridden for beneficent purposes? Such as when the finding is dire and requires immediate attention. Do we hold people to Ulysses contracts, in essence, of saying, I don't want to know? And then the second open question is if patients express a wish that they actually learn about the incidental findings, are there any circumstances under which clinicians can or should override that wish? The person says, I want to know everything. Well, do they want to know that they've got a normal variant on an artery that may have no clinical significance whatsoever? How much should we be disclosing? So those are open questions for us to discuss. Our sixth finding from our working group is that clinician-patient communication is enhanced by patients' understanding of the objective risks and benefits of procedures. Patient estimates and assessments of risk are not always accurate. Problem somewhat, I'm not always sure, salubrously indicated the problem of patients having innumeracy. But anyway, if the patients do have difficulty sometimes grasping this kind of knowledge, it can negatively affect their decision-making process. So the proposal we have is that professional organizations and medical associations develop standards for clinician-patient communication concerning how best to communicate difficult to understand results and often misinterpreted concepts, and methods of enhancing clinician-patient communication might include information about absolute risk rather than, or at least in addition to, relative risk. Those concepts, if you're not familiar with them, the relative risk, which is often given, is that you have a 25% reduction in your mortality from if you get this test, and that might be from 0.4% to 0.3% in absolute terms. We tend to present things too often in relative risks and not in absolute risks. That we ought to use population-based evidence, again, when we're developing our tests and recommendations, and not simply using what's often the ascertainment bias of doing things according to data generated at places like the NIH or the University of Pennsylvania, of people who come to these places because they already have findings, but rather based on population data. And then the possibilities of employing decision aids and graphical representations in having these kinds of discussions. So what's the chance of my having an incidental finding? It's 1 in 1,000. People might not appreciate that unless they had some sort of graphical representation of 999 white dots and 1 black dot on a board to sort of help make those sorts of things clearer to them. So those are our discussions at present from our working group, and I guess the first thing to do would be invite my 2 co-members of that working group to see if they have anything to add or subtract, and then I guess we'll open it up to discussion.
I'll start, I guess. I thought that was an outstanding summary of our discussions, and I feel very pleased with the outcome of what we determined. I guess I just have to comment on the open questions because we had a lot of discussion about the telling of patients. In a clinical context, what really is the role of a physician in telling a patient about an incidental finding? And even looking for the incidental findings in the first place. And I come from a background, I'm a pathologist, so when I think of incidental findings, they're not all that incidental. As a pathologist, in a lab test or in a specimen, a tissue specimen, you look for everything. You don't stop if they tell you we're looking to see if the patient has X cancer. You don't stop. You look at absolutely everything, every infection, anything you can possibly find. And I've never even considered those incidental findings. I consider them findings. So I think if it's a significant finding, it needs to be told to a patient. And so those 2 open questions of when you might not and when, if the patient didn't want to know, when you wouldn't tell, even if it was important, I'm still on the side of trying to convince a patient to know. And if a patient wants to know, telling them pretty much everything. But we had real disagreement on that. And so I think as a group, we need to talk about that whole issue more.
Thank you. I'd like to also thank Dan. That was a wonderful summary. And I might bring up 2 points. One was generated this morning with our discussion about filtering. And the second, just some further nuances of the educational issues that we face in the clinical arena. So I'd like to ask, I very much like the concept of stumbling upon as a definitional guidepost for what an incidental finding is. And we understand, I think we have some consensus about the guidelines for following up incidental findings once detected. Another interesting question is how hard should we try to stumble? how hard should we look to identify incidental findings? And let me give one example from my own experience. A young man comes in to the hospital with paralysis from an inflammation of his spinal cord, a myelitis. And this can be visualized and the cause identified through neuroimaging studies, which did identify the cause. Missed on the reading of the study were several small abnormal lymph nodes in his abdomen that subsequently, 1 year later, developed into a lymphoma that could have been detected earlier. An abdominal radiologist would have found those small lymph nodes, but a neuroradiologist or a neurologist probably not, and in this case, did not. Now, the test of reasonableness, I think, is really brought to the fore here. And one can continue to dig into all sorts of findings that arise in a clinical arena, but I think we do need a very reasonable filter to guide when further evaluations stop. So how many experts need to look at a data source?
In that spirit, if I might, I'm a little surprised by a couple of the recommendations. By the way, terrific work, thank you all. But the three of you being MDs, and I'm not, so you can just say, no, Jim, it's no burden at all. But this reasonableness issue struck me in two of your findings. Your third finding, where it says it's the clinician's fiduciary duty, requires them to actively seek incidental findings, in other words, to try hard to stumble. Is that to be understood that we should be responsible, the physician should be responsible for all things that a particular test could reveal? And in a subsequent recommendation and finding, you suggest that that the clinician should inform the patients about the possibility of all incidental findings in their test. So if someone comes in for, with bronchitis or pneumonia, and they say, we're going to get a chest x-ray to look at that. Is it the recommendation here that there should exist somewhere a list of the 17 other things that a chest x-ray should, right? That there should be a list, and that the patient should be told, now we could find 16 other things here, and that you as a primary care physician would have the responsibility, or whoever reads the x-ray, radiologist, would have the responsibility to check off all 17?
Let me,
What if the list is 1,000?
yeah. Let me respond. The first is that what you've got is a draft, right, and it's not the final. And if you were listening, at least with recommendation clinical finding 3, I sort of subtly altered it as I was speaking it. So I said it requires them to review all the clinical data they generate and not to bracket or ignore potential incidental findings. And I think that's probably a more accurate way of practical way of saying it, yes.
Let me just say a few things in defense of the direction these recommendations are at. In some sense, you could see the thrust of these recommendations as trying to minimize having to worry about truly incidental findings. In other words, given that you want to have practices in clinical practices in which you're not getting clinicians who have no real expertise in an area just stumbling on something that they then have to report, it would be good medical practice in the clinical area to organize. This gets back to what I was talking with Dr. Perrins about. It would be good to organize clinical medicine in a way, if it can be done in a cost-effective way. And by the way, teamwork now is much more trustworthy and cost-effective than just having one person read, results. If that were done in a reasonable way, as these recommendations suggest, not trying to do a list of 1,000, but if there are a dozen most likely what would be a dozen likely incidental findings, make them non-incidental by saying we will look for these. It's not that expensive or hard to do it. We have teams that are good at doing these. And if we find something on this list, we're going to report it to you because you could do something about it. That's the thrust I see of most of these recommendations, and then educating clinicians to know what discretion is in developing these practices. And because we ought to know going in, both we the clinicians, which I'm not a clinician, and we the patients, educated patients, what could be found, what to expect. I think they're, tweaking aside, this is a very ethical and practically reasonable thrust.
Thanks, and just to, I'm sorry, this gets so loud when I get close to it. Again, the word all you picked up on, I'm sorry, I missed that one. That's probably stronger than was the thrust of our discussion, which was probably closer to Amy's. Again, I'm not sure that for every test we have to generate a very specific list, but I think the main thrust was to make patients aware that there could be incidental findings and maybe give them a couple of examples of what those might be, because again, sometimes the unusual happens. Yeah.
And they're not, let me just say that while definitions are good to have because you know what you're working with, we also shouldn't be slave to definition. These are no longer stumbling on incidental findings. They are this is an accurate way of saying it. They're incidental to why the test was ordered. The findings are no longer going to be stumbled upon. They are going to be looked for because their cost of, it's reasonable in both the cost and given the benefits that could be had here, it's reasonable. And to say at the flip side, I think Dr. Hauser's example is excellent. If it would be inordinately difficult to have somebody else look at these x-rays routinely, then you don't do it. But if you're working in teams, and it would be pretty easy to routinely ask another specialist to look to catch the cancer, it's probably then it would be a good thing to do.
I might just one additional point of emphasis that I'd recommend for our report, which would suggest that our healthcare systems not disincentivize clinicians from having adequate time to communicate with patients.
So, thank you. I had two questions. One is whether or not when you talked about generating evidence for cost effectiveness, you talked about evidence of other kinds of burdens besides cost, like
Besides financial costs.
yeah, distress and things like that. That's one thing. And the second question actually was, did you talk about payers, third-party payers at all, and what we might say to them?
We did talk about burdens other than financial ones, sort of, again, the kinds of questions that arise when one learns about a disease which is potentially lethal, but which is incurable, and certainly whether people want to live with the burden of knowing that. And we have good evidence that members of the population vary dramatically about their wish to know that kind of information. So we did talk about those sorts of costs. With respect to third-party payers, I don't think we addressed that question, although I'm sure they would be interested in the cost-benefit analysis data that we were discussing, because it's sometimes their own policies that have resulted in insurance schemes paying for certain kinds of tests that are bundled, and it may be that actually would be a surprise to them that it was actually not cost effective to do so.
Thank you. This is incredibly useful, and I really appreciate how much thought you all put into this context and bringing your expertise to it. I was part of the research group, and we had a similar open question around this question about should you override patient decision-making. And I think it's a really difficult one as to deciding the extent to which you will honor the patient's desires and whether or not they can fully and adequately waive their right to have such information and truly appreciate what that means, and then also understanding the burden in this case on the clinician if they are bestowed with knowledge about, suppose the patient says, even if you stumble upon, an aneurysm which is inoperable and there's nothing you could do about, which tomorrow I might, drop over from, I still don't want to know. And now the clinician has that knowledge and has to live with that knowledge, knowing, they might be able to do something. I think it's really hard to imagine honoring the patient preferences in that context, understanding the burden it would place on the clinician in that context. And at the same time, I think I narrowly come down on the side of favoring patient preferences to be able to say what they wish to know and what they wish not to know, and that the burden is really on the front end of ensuring that we truly adequately apprise individuals about what it means to waive it. But it's not an easy case, I don't think. I think it's a really difficult one. So it'd be helpful, I think, to hear some of the context-specific deliberations you had around this in the clinical setting.
Could I just, because I think you had this as an open question, and you had two open questions, right? One I think is easier than the other, but let me address the one, the same one Nita is. If patients express their wish not to want to learn about a life-endangering situation that is curable, then I don't see the argument for why any clinician has to treat such a patient. In other words, given that the Hippocratic Oath requires doctors to protect the health of their patients, I think it is incumbent on clinicians. I think this would be, to say, look, if we do this test, if I find out anything that would enable me and and my colleagues to save your life, that's life endangering and we could save your life, I'm going to tell you about it. And if the patient says, no, I don't want to know, then the clinician should say, I'm sorry, then I can't do this test, because the test we're doing is to help you be healthy. And you're telling me if I find out something else that could help you be healthy, I can't tell you about it. I think it's perfectly respectful of the autonomy of a patient to say, I respect your wish, but I can't be your doctor. And I think that's a solution to the problem. I know that there are people who say, well, autonomy means you can pick and choose what you have other agents who have sworn obligations to do for you. But I don't see the moral argument there or the legal argument there. I don't think you can pick and choose a doctor who's not, if he finds out or she finds out something about your life that's life-saving, will not tell you, because then he or she is no longer a doctor and a clinician. So I really, I feel that I really do think while, I think there are very few people who will say that, but I think the few who do, it is perfectly moral and perhaps, just let me stick with the ethical, is perfectly ethical, and indeed I think incumbently ethical on clinicians to say, I really can't be your clinician under those circumstances.
I think I agree that that is absolutely a reasonable response from a physician to say that isn't a burden I'm willing to take on, or I don't feel that that's consistent with my ethical obligations. But what happens for the physician who chooses not to do so? So I think it would also be permissible for a physician to say, I understand that, and nevertheless will treat you, and then do they have the right, to override the patient preferences under those circumstances? And I think the answer is no. So I think if they feel like they would override the patient preferences, then declining to treat the patient would be the appropriate response and the ethical response.
So this goes to what Dr. Hauser said is need for clinicians to have the time to explain. I think the obligation, the professional obligation, based in the very reason we have medical practice, is for a doctor to try to persuade her patient that if she finds something that's life-saving, she's going to inform the patient and do everything she can, and it is within her power. There's a totally different case if she can't do it then. And I think if the patient, I also agree, if the patient says, I don't want, under no circumstances do I want to know, then the clinician shouldn't treat the patient. It's really unfortunate, and I think it's I think we're dealing with an extreme hypothetical here. But I think what isn't hypothetical is what we agree on, I think, is the ethical obligation for doctors to say, I'm going to tell you this, and because that's not my practice as in just routine, that's the fundamental reason I'm a doctor.
And you're asserting this around dire and life-threatening cases, not paternity or issues like that.
We have to start with the clear cases, and there's a flip case that's just as clear to me, which is the case where it has nothing to do with ultrasounds that show the sex of the child. If a doctor said, I'm going to tell you the sex of your child whether you want to or not, that's equally wrong and not consistent, because the sex of the child has nothing to do with the health of the pregnancy. And there, I think, autonomy requires, the respect for the autonomy of the patient requires to go along with the patient's wishes, because it doesn't violate the fundamental reason why doctors are doctors and are licensed as doctors.
Yeah, I think I in part agree and in part have some issues. I think if it's the central reason that the test is being done, then it seems to me that you're absolutely right, that there doesn't seem to be any reason to do a test, the sole purpose of which is to find something that the patient says they don't want to know. That doesn't make any sense. But there are plenty of situations in which a physician undertakes the care of a patient under some significant limitations imposed by that physician. The sort of stock example is the Jehovah's Witness, right, who says, care for me, but if I need blood, even if it's life-threatening, don't transfuse me. and we will care for such a patient. So let's try to think of an example of somebody who wants to have a CT scan, but we think that we want to convince the patient to get it, and they're frightened, and they say, well, you know, the reason we're doing it is to see whether they've had a stroke or not, and they say yes, but if you find a cancer, don't tell me. Now, this maybe is partly the entanglement, right? I get in there and I do the test to find the stroke, which is what I thought happened, and it turns out I'm wrong. The patient has a cancer, and I may have, you know, gone through as much appraisal about this as I can with the patient, but then I may come back to Barb's point after I find that out. I would go back and talk again after I've found that and try to persuade the person. And ultimately, if they said, I don't want to know, if you tell me it's not a stroke, that's all I wanted to know, I would feel horrible about that, but would probably ultimately, you know, respect it. I'm certainly not going to.
So I wonder whether we
give them
may be
radiation,
actually in heated agreement here. I think actually.
You are, but I think I'm not.
Okay, well, we are. Let's see if we're in heated agreement then. And I thought I was in heated agreement with Nita, but maybe not. Because I think that if a clinician says, so here are the things. A clinician tries to persuade her patient that if she finds something that she can cure or can be cured, she will tell the patient. Tries to persuade the patient, and should try to persuade the patient. I think we all agree on that, right? And there should be a practice of saying what the possibilities are. Beforehand, right. Okay, then the patient, it's the second, so we totally agree on that. The second case, the patient says, nope, I don't want to know. If that's the primary reason, then clinicians, we all agree the clinician shouldn't do it. Okay, so we agree on that. If it's the secondary, then we also agree that the clinician can say, I really can't treat you under these circumstances because I feel obligated to do it. We agree on that. So there's no disagreement. So the open one was the patient says, I just want to know this and not that. And I agree that if the clinician feels that it's important enough to do the primary and the patient will be saved there, that the clinician has tried to persuade the patient, then I agree, actually, that the clinician could ethically go ahead and not tell the patient. I think that's that because the clinician is still doing good as a clinician, and the clinician's tried her best. And there are cases, and I don't think this is purely theoretical, there are cases, it's not, somebody doesn't have to be nuts. They can have a religious reason, or they can have a moral reason that they've gone through enough with this, and they just don't want to know. So I think we are in agreement, actually.
Yeah, no, I
Barbara and then Anita.
So I just want to say, this is why deliberation is helpful. I actually think that we parse this so on both sides, so what a clinician cannot be obligated to do and what a patient can, that we're in agreement. Mind you, some people, like Barbara, will think clinicians should only do it if they can tell everything. But maybe, but you would still agree with the list, I think, of how we went down it.
Pretty much. And I'm in sort of agreement and sort of not, but let me just at least make it harder, if I can. You're using a cutoff of life-threatening, and that's clear. I think we all would agree that we would certainly try to convince anybody if it's life-threatening and there's something you can do about it, to do something about it. But what if it's just a treatable something? It's, it's not going to kill them, but it's treatable. I think any physician would want to tell the patient. I don't think there are any physicians that wouldn't think if there's a treatable something, it shouldn't be treated. What if it's something that we don't know exactly the significance of it right now, it's not normal, but we might know in 5 or 10 years? I think most patients you would try to convince that they should at least know so that if something comes up that's treatable later on, it can be treated. So there's a spectrum of things, and I think that's where the real physician input is to try to convince the patient to know as much about their own self as possible. And I can certainly see the times when a patient says, enough, I'm sick enough with what I have, I don't need to know anymore, or when they simply can't comprehend it. But in the ordinary circumstances, I think you ask any physician and they won't want their patient to know as much as possible. And that's sort of a new moralistic for physicians. It's not the old-fashioned
Right.
kind, which was exactly the opposite.
Right.
You might tell the family, but not the patient.
But we agree on that. That
Yeah.
isn't not.
Right. But it is a
we-
bit of what comes into play in all of this. And if you try to tell physicians that you shouldn't tell a patient because it might cost too much to work up a finding, most physicians are going to balk at that. They're taking care of their individual patient. They're not taking care of the health of the public or the finances of the federal government. They're taking care of a patient for treatment of, and the best outcome for that patient. And that has to be the highest priority.
But the only thing I think is worth adding to this, because on record, is that there are patients who for religious reasons, but also who for non-religious reasons, and I know, several, who have gone through so much medically that they don't want to deal with more, and there are doctors who respect that, but it's always, as Steve said, always that on both the patient and the doctor's side, this seems reasonable if there's discussion, if there's time to actually talk it through.
One sentence to that, which is, so I think absolutely beforehand, the only point of difference I had with what Dan said was that I would be hesitant to have the physician go back after they discover a secondary finding and try to convince the patient again, because at that point they're saying, look, I found something, so I really want to tell you. And it seems to me if the idea is to avoid the harm of having to know, by the time you do that, you have, you've notified the person and created more anxiety. So I would want that discussion to happen beforehand.
Judgment.
I actually need to disagree. I think that reconsenting the patient after you've discovered something of interest is actually the right thing to do, but that's not my point or my question. My question is about the pragmatics of patient ignorance, because we live in a world of electronic medical records, and all of us have access to our medical records. And so aren't these secondary or incidental findings going to be in the patient's medical records? And if the patient wants to go to their records to find out their cholesterol or their white blood count, they're going to see, oh my God, I have a tumor in my brain. So I didn't want to know that, but it's there. So are we also urging that we not include this kind of data in the record? But if we do include it in the record, aren't we in a way disclosing to the patient that they have conditions they might not want to know about? How do we pragmatically, again, in this day of electronic records, deal with this? I mean, I can go right now to, MyPin Medicine and find out all kinds of stuff, get my x-rays, my MRIs on my iPad. How are we going to keep stuff from people? Are we going to assume that the world consists of people who don't access their medical records and those who do? Since we are encouraging people to have and take access to their records, aren't we also encouraging them not to be ignorant about their conditions?
Tough question. Access is voluntary at most institutions, but I think there are all sorts of nuances. As we all know, if certain fields of information are expected to be kept private, it's very hard to cordon those off so that they're seen by the patient and the physician and not the secondary and tertiary physician and other clinicians. What about research tests, and how does one stratify or segregate research tests from clinical records? These are very tough questions.
I think that on the typical patient electronic record, all of their health conditions are listed in a long list, whether it's, diarrhea or it's cancer. It's on one list. We don't, I think as a matter of practice today, partition and segregate medical information to keep some information away from patients. So I'm just curious as to what kind of model we're dealing with here of patient information.
I'll respond a little bit. I think it is making it very difficult to have anything that is even utterly inconsequential that's not disclosed to the patient and discussed, because patients get the records, and so the even the comprehensive metabolic panel comes back with a calcium which is 1/100th of a point below normal. There's an asterisk next to it, and the patient is going to ask, and so it increases in some ways the burden of having to explain away things that are trivial to patients that we wouldn't have had to have done before. I would not have, I'll have to say, if a calcium came back 1/100th of a percent below the normal range, I would not typically disclose that previously to a patient. Now I have to. Because the asterisk will come up, and they've got to know this. I would sort of dismiss it, particularly if I wasn't looking for it, as one of those 1 in 20 things that's going to come up slightly statistically abnormal and wouldn't have otherwise talked about it. So it increases, I think, the burden on clinicians to discuss everything. If everybody looks at the x-ray and there's a cyst on the kidney that's discovered when you were doing a CAT scan of the liver, you absolutely have to talk about it to the patient. So I think what it does is put pressure on finding whether there's anything that is so utterly inconsequential that you're not going to talk to the patient about it. I think sometimes we're going to be in more of a position of having to about everything.
Just one final point, that information technology can help us with solutions. For example, at our institution, patients can enter some information in an anonymous mode so that it is not part of their widely distributed medical record. The other point that I wanted to make, and just as based on my experience, and wondered how the others felt about this, when Barbara speaks very properly about cost effectiveness, which has all sorts of implications, and we have many different types of responsibilities as clinicians to act in a cost-effective manner. But in a practical sense, when we consider costs at the bedside or in the clinic, the costs are not the financial costs, the overwhelming majority of cases. They are risk to health, protecting against anxiety, considering pain that might be inflicted by needless diagnostic tests, inconvenience, wasted time, etc. So I think acting in a cost-effective way is really acting in the best interests of individual patients.
I think it's extremely important.
If I can just add to that, I didn't want anybody to think that I don't think physicians should be cost effective. I think they should, but that's really why we did the recommendations relative to finding the data across broad batches of people so that we can do it. And it doesn't have to be each individual patient that we do it on.
I would like to suggest we give you a little bit of input on your second question before we break for lunch. But before we do, I would, there's still some fuzziness in my understanding. It's probably fuzziness in my understanding and not the clarity with which you understand your recommendation about the situation under which physicians could agree with a patient's request not to know. So is staff going to try to write that up and circulate to us so we can see that? The second question, the complementary question, is the one about the case where the patient says, yeah, I want to know everything, and the doctor's wondering, well, I don't really want to worry them with 1/100th of a percent lower. Input for this, input on that particular open question.
This is consistent with the other thing that we agreed on. I think clinician is not under an obligation to tell a patient to, so let's begin, make it very clear. So,
Yeah, help me.
So, okay, a patient comes in for a particular reason, a good reason to have, and the clinician orders the right test. There are, to use your example, I won't use 1,000, but let's say there are 100 incidental findings, 50 of which are trivial. And the patient says to the clinician, I want to know every finding. The clinician not only can, but should say, I'm not going to give you every finding. And if this is consistent with need, if the patient doesn't want to do it under those circumstances, fine. But if we're going to be cost effective in time and cost of clinical treatment, then we can't have a system where patients, just because they want to know things that we stipulated are trivial and not necessary for their health, have just a right to order clinicians to take the time and the effort to do them. So I think that one's easier, actually, and totally, I think what I just reviewed is totally consistent. Now, they're going to be, in all of these, they're going to be gray areas, but to get the basic ethics of this down, I think would require that answer.
I think what matters is how we define what the duty to disclose is, because as you've described it, I completely agree that, or as Dan points out, there are many times you're 1/100th of a point off of normal, and the idea that we would require physicians to take the time to explain it all is far too burdensome, and I would think if a patient doesn't like that, they can go elsewhere. But to Anita's point, now we have electronic patient records and access to our health records. So I do think it has to be included in part of the record, meaning that the report itself, the actual lab tests, need to be available to the patient so that they can have access to the incidental findings that arise, but not that there is some additional burden that should be imposed on physicians to actually discuss it and review it with patients.
But does that suggest that in order to have a complete set of data that need to be presented, that every spinal X-ray needs also to be read by an oncologist? No. And I hope that answers.
The idea would be the judgment of the physician would apply for, if they think it's something that's a meaningful finding, then they actually need to discuss it with patients or do the additional kind of research. But if it's a trivial thing that in their judgment is truly trivial, then it's part of the record, but not something that they actually have to take additional steps to address.
By the way, I think it's important really important, Jim, that you raised it, because we hadn't addressed it. But I also think that it opened, for those individuals who want to know much more about themselves than it is responsible for a clinician to give, that's where direct-to-consumer hits its stride, because you can pay out of your own pocket to get gobs of trivial information about yourself, and maybe you will stumble upon something that in the normal practice of medicine, it's just too small a probability to require clinicians to report. So, direct-to-consumer is there, and that's why it's called DTC. It's there to give consumers what they want. And I totally agree with Anita. We don't want it, and I think Eric Perrin said the same thing. We ideally don't want it to be a substitute for the basic good medical care that all people can get. But it can be an add-on for those people who are intensely curious about everything about themselves, and they can go online and order up a gob of information and pay out of their pocket for it, but not have it be something that the public pays for all people for healthcare.
Again, I think that Anita's question about the pragmatics of patient ignorance, and I like the phrase, just, I have to say, as a clinician, is making this exceedingly difficult. I will draw the line at doing a workup on the calcium that's, 0.01 off the mark. But increasingly, they will know, and I will need to take the time to explain why they don't need to be worried by that. And that will be when they get, a CT scan or an MRI back that was done because of an abnormality in the arm, and it shows that they have a normal variant, that they don't have an ulnar artery. Let's say they have only a radial artery. That's something that I probably is never going to be of any consequence to them unless they get an art line put in, and somebody should be doing an Allen test before they do it, but probably won't go through. I have to say what that is to the patient, because it will come back in the test and explain why they don't have to worry about it. And I think that's increasingly going to become part of our job, and I don't know a way around it, because people will be very worried when they see anything that is abnormal.
And as you say, technology may not give us a way around it, but as a principle that we would state in our report, we would allow for that. I think we've come to the time when we will break for our lunch. I hope you feel we've moved the ball forward just a little bit in these conversations. Great work by the group, and look forward to our discussions this
Thank you
afternoon.
for the
We
group.
reconvene at 1 o'clock. Thanks to you.